Thank you, and thank you for the opportunity to talk with you today. As mentioned, I'm the medical director of lung transplantation here at Massachusetts General Hospital, and I wanted to talk a little bit just about how we utilize these tests in our lung transplant population, which can be a little bit different than how they're utilized in other organ transplants, such as kidney transplant. So in lung transplantation, not only do our patients run the risk of rejection of their allograft, but because of the exposure of the lungs to the environment, our patients are also at high risk for infection. And these tests, such as the cell-free DNA tests, are great tests to look for allograft injury, but they don't specifically delineate between infection and rejection. That said, they're an important part of our armamentarium in monitoring the health of these allografts. And I look at these tests along the lines of other tests that we use to monitor the health of these allografts, such as pulmonary function tests and other blood tests. We also do invasive biopsies, and as mentioned previously, there's quite a bit of variation among programs and even among providers in the approach to the frequency of biopsies. And I think where I see these tests really standing out is they provide us the opportunity in a non-invasive fashion to more closely monitor the health of the allograft and to pinpoint times when we need to do more invasive testing, such as a biopsy. I don't see these tests eliminating the need for biopsies, but I do see these tests helping us decide when to perform an invasive biopsy, which are not without risk. There are a couple of other scenarios that these non-invasive tests, such as cell-free DNA, come in handy. Sometimes patients are too sick to safely undergo an invasive bronchoscopy. And these tests can be utilized to tell us if there is actual damage happening to the allograft, or if the allograft is functioning well and we just need to focus on other areas of the patient's overall condition. And the next area that I think that these tests are beneficial is in monitoring response to therapy. For example, when patients develop an antibody-mediated rejection, that requires a treatment over the course of about 2 weeks, followed by serial treatments with other therapies over the following months. We have experience using this test, and we monitor these cell-free DNA levels, and we see that these levels are elevated in settings such as AMR. We also know that these levels tend to decrease when AMR treatment is successful, and therefore are a good marker of response to therapy. And these uses definitely fall out of the range of what's been listed in the current LCD proposal. And so I wanted to just highlight some of these nuances as regarding use of this test in lung transplant population, and to highlight the importance of reimagining how these tests are approved for use and maintaining provider independence and deciding when is the most appropriate time and way to utilize these tests for monitoring patients. Thank you for your time.